If I was on a desert island and I only had one monitoring, it'd be capnography. So it is absolutely my favorite piece of monitoring equipment for anesthesia as well.
So many questions about that desert island scenario. Hey everyone, welcome back to Vetfolio Voice. In this episode, I was joined in person in the studio by Dr. Sarah Shippey, who was just absolutely lovely. We dove into one of my favorite topics when it comes to veterinary anesthesia, capnography. Capnography is such a useful, such an important tool, and we really dug into that in our conversation. We talked about what capnography is, why it's important, the mechanics behind it, including different types of capnographs, how to interpret waveforms, and accessibility of capnography for anesthesia in our patients. We also talked about the role and the influence of end-tidal CO2, what it tells us, why it matters, how to think about this information depending on what the procedure is and any comorbidities our patients may have. Dr. Shippey was incredibly knowledgeable, such a joy to talk with. I mentioned this in the episode, but I started my veterinary journey in the anesthesia department at the University of Florida more years ago than I will admit here. So some things we discussed were topics I've studied and talked about many, many times over the last more years than I will admit here. But during this conversation, I definitely had a few light bulb moments. Even though these were concepts I've heard countless times, the way Dr. Shippey explained them and the context she gave them just kind of made everything click for me in a way that it hadn't before. So stick around, you're in for a great episode. Let me introduce Dr. Shippey and we'll get into our conversation. Dr. Sarah Shippey graduated with her veterinary degree from the University of Missouri in 2017, where she also completed a Master's of Public Health degree. She completed a rotating internship in small animal medicine and surgery at Louisiana State University. Continuing to pursue her interest in anesthesia, she completed an anesthesiology and pain management residency at the University of Florida, where she also completed a master's degree in veterinary sciences in 2022. She's continued to work at the University of Florida as a clinical assistant professor, and her clinical interests include pain management techniques and exotic animal anesthesia, which we also talk about a little bit in this episode. So let's go ahead and get into it.
Are you passionate about animals and love helping people? In the fast-paced world of veterinary medicine, exceptional client communication is just as important as quality pet care. As a customer service representative, you're the heartbeat of the practice, the first and last person clients see. You provide comfort, support, and trust in every interaction. This course is designed just for you. It's interactive and practical, featuring real-world in-clinic video scenarios, engaging knowledge checks, and printable resources to give you the tools, confidence, and strategies to handle any challenge and elevate the client experience. Register today for the Certified Veterinary Client Service Representative course on vetfolio.com.
Well, I'm excited to be able to record this episode in person. It's so much nicer sometimes to talk to somebody face to face, not through a screen, actually be in the same room. So Dr. Sarah Shippey, thank you for joining me to talk about capnography.
I'm happy to be here.
Yes, I'm happy to have you. And I'm excited to talk about capnography because long ago, before vet school, I started my journey in the veterinary field at the UF anesthesia department, which is where you're joining us from. And capnography very quickly became my very favorite monitoring tool for anesthesia. So yeah, I'm excited to talk about it.
I joke that if I was on a desert island and I only had one monitoring, it'd be capnography. So it is absolutely my favorite piece of monitoring equipment for anesthesia as well.
So many questions about that desert island scenario. But yes, I would agree. With lots of questions, I would agree.
Absolutely.
So, let's talk about that a little bit more. Why is capnography so useful? Why is it so important? What are we learning from that monitor about our patients?
So capnography, on the simplest terms, is really telling you about ventilation for your patient. So it's telling you about gas exchange of CO2 from the blood to the lungs and then what's getting exhaled. So it is telling you, is your patient breathing? And again, do they have adequate gas exchange? But kind of on a more deeper level, it also is telling you about perfusion. So you can't get, unless you have good cardiac output, unless you have good blood pressure, you're not going to have good return of CO2 from the peripheral tissues back to the lungs. So it is also a key kind of telling you, do you have good blood pressure? Do you have good cardiac output? So it kind of is twofold in that sense. So from a monitoring standpoint, is great in that it's telling me, is my patient breathing, but also, is it having good venous return?
Yeah, and I think that's why it became one of my favorite monitoring tools, is because of the cardiac output component, where my ECG, my pulse ox, those can lie to me.
Absolutely.
But my capnograph's not going to lie to me. It's always going to be honest with me.
Yes. There's a lot of things with pulse ox. I say pulse oxes have the biggest futz factor. A lot of patient movement, extraneous light, like so many things can interfere with it. But a capnograph really is, there's very few rare circumstances where it's going to lie to you. So it's kind of the most reliable monitoring you have.
That's how I feel. So I'm glad to hear you say that, which is why I like having it so much. Yeah, I don't know. I feel lost when I don't have my capnograph to know kind of what's going on. And gosh, I did not have a capnograph for years. And it was, now looking back, I'm like, I don't know. It seems like very risky is the right word, but just different from the anesthesia that I'm able to do now versus not having a capnograph. Yeah, I just feel like I have a lot more information at this point.
Absolutely. Having done both, kind of only had a pulse ox or my fingers to palpate a pulse, up to kind of, I'm in the world of academia and the ivory tower and all kinds of crazy monitoring. I think capnography is just invaluable. I think I would pick it over a pulse ox in most cases.
Every time. Yes, I was in most cases, sure. I guess we shouldn't speak in absolutes, but yes, I'm right there with you.
I think it's just as valuable, I should say.
Sure. Maybe more valuable. So, let's talk about that waveform, because I think that's where sometimes people do maybe not get as much value out of a capnograph, is not putting the pieces together as far as what the waveform of a capnograph means and what we're looking at. So can you tell us a little bit more about what we're looking at when we see that capnography waveform?
Yeah, absolutely. I will preface that by saying there are some that are just capnometers that are just give you the number but don't have the waveform. But I think if you're going to invest in capnography, if you've never had it, I would get one with the waveform, so that has the capnograph on it. And that waveform, basically, it is, most of them are what we call time capnography. So you've got time basically on your x-axis, and you've got your concentration of CO2 on the y-axis. And what you should see is a nice, pretty top hat, is what they typically say. So it's basically a square waveform, and the first kind of, or the baseline of it should be at 0, and that 0 mark is basically inspiration. So during inspiration, you're basically having a lot of fresh gas inflow into the lungs, so your CO2 is very low in that concentration or at that stage. So it should be, again, around 0. Then as the patient starts to exhale, you're going to have initially washout of the anatomic airways that don't undergo gas exchange, so your trachea, your mainstem bronchi. So you have that kind of initial where there's no CO2 there, and then you have a very rapid upswing. So that rapid upswing is the initial alveolar gas that carries all of your CO2. And then it goes to basically a plateau. So the plateau phase is, again, all of your alveolar gas that is then getting exhaled. And then it goes to basically a second point where that's the start of inspiration. So then it drops rapidly back to 0 during inspiration. And then, again, the next breath basically continues. So you should have that, again, nice square wave top hat formation for a good capnograph.
I mean, I get so excited when I see those square waveforms. I'm like, you're doing great. But I actually didn't realize that what you're saying makes sense, that baseline includes inspiration there. I always think of like expiration is the upswing and then inspiration is the downswing, but that makes sense that once you reach 0, you can still be inhaling and there's not CO2 going through, and includes the beginning part of exhalation.
Absolutely.
Yeah, that makes sense, which comes in handy when we're talking about troubleshooting the capnograph. Things like not going back to baseline and having a positive FiO2, a fractured inspired FiCO2.
Yep.
Yes, a positive FiCO2 where we're not reaching zero and we are rebreathing some CO2. What are some of the things that might change that beautiful square waveform?
Yeah, so starting, I guess, with rebreathing CO2, I think that's the number one thing I see people get a little bit caught up with. So if your baseline is not reaching back to zero, that by definition is rebreathing CO2, and it depends on what system you're on. So if you're on a non-rebreathing system, like a Bain block or a Jackson Reese, there's no CO2 absorbent in that system. So what is getting rid of the CO2 from your patient is really a high fresh gas flow. So that's why if you look at a lot of the textbooks, the math for it is you want 200 to 300 mils per kg per minute, roughly, of a fresh gas flow to basically push your CO2 out of the system. So in that type of breathing system, really the only reason you're rebreathing is if that fresh gas flow isn't fast enough or high enough. So that one's very easy to troubleshoot. In a circle system, it's a little bit trickier. There's a few other reasons. So one big thing is if your CO2 absorbent is used up or expired, getting a system in your practice of regularly changing. We change it every Monday so that if it's dried out over the weekend, it's also kind of fresh for the beginning of the week. If you have a incompetent one-way valve. So in a circle system, what basically pushes the gas through the system is the two inspiratory and expiratory valves. So if one of them basically gets stuck open, oftentimes the expiratory valve, your entire circle system essentially becomes apparatus dead space. So it's harder for the gas then to basically move out of the system. And so that's when they will rebreathe. If you are for UF, we see a lot of patients, so a lot of the condensation from our patients gets caught up in the system, and that kind of can get those valves, because they're a little plastic, very thin, so they often get stuck open, so that's often what we see. And kind of the last reason is if you have a lot of apparatus dead space, if you have a lot of like connectors or you have a very long endotracheal tube, all of that is where you have bidirectional gas flow. And so you can have, we consider that apparatus dead space. So if you, again, most of the time it's a very long ET tube. That's why we often will cut down ET tubes, have a lot of elbow connectors, etc. That's all going to contribute.
That makes sense. I feel like the dead space component has always been conceptually where I've struggled. Mm-hmm. Like, understanding the anatomy of the anesthesia machine and how the valves work and the non-rebreathing system, all of that has made sense to me. But the dead space is somewhere I've always struggled. But for some reason, when you just explained it there, you explained it beautifully. And like, I had this light bulb moment where I'm like, oh yeah, all right, I see it now. Like, you see where it's coming from. I mean, I knew dead space bad and will create problems, but why exactly that was contributing to our FiCO2. Thank you for explaining that. Like, I just had this moment where it made so much sense.
Yeah. And I guess I'm spoiled because a lot of my patients in academia, we place on mechanical ventilators, so it can somewhat overcome some of that apparatus dead space. But if you have a small patient that has a kind of weaker lung capacity that's spontaneously ventilating, if they have to pass through or basically try and push gas through so many connectors and so much apparatus dead space, it inherently makes it more easy for them to rebreathe.
Yeah, absolutely. And, when you talk about that, it kind of brings up our capnograph setup, our monitors, because we talk about, is it in-stream versus side-stream? Is that the right terminology?
Yeah, mainstream is often what, it's referred to. So, there's two different types. Again, mainstream versus side stream, and there's pros and cons to each. The historic mainstream capnographs, the nice thing is they didn't have a delay, so they read the CO2 concentration right there at the patient, like at the breathing circuit. Downside is that you need the technology to this, basically the infrared technology at the site, so it was often very heavy. It's also, again, more expensive, so if you drop it or break it, can be expensive to replace. Newer mainstreams, I guess, are a little bit easier, so they still are heavier than typically your side streams, but they've come a long way. But I think more common is the side streams, where it's basically aspirating a sample from your airway and pulling it to a distant site or your distant monitor. So there's a little bit of a delay. It's not total real time, but it's pretty fast. It's accurate enough for a lot of our purposes. And then it reads it basically at the machine level. So for the side streams, the advantage is they're often very lightweight plastic. They're fairly reusable, but like you can drop them. They're somewhat disposable, like if they get gunky or dirty if you're doing dental practice. So they are probably the most common that I see is more side streams now.
Yeah, that's definitely what I'm more familiar with. I kind of forget that the mainstream exists, but it is good to know that they've come a long way if that is the best option, for whatever situation. I've seen the delay, but I haven't noticed it being like clinically significant at all.
Typically it's not. Yeah, in most cases I don't really notice clinically significant delay time.
Sure. And then have they shown any difference? I can't imagine there would be a major difference between the numbers we would get off of a mainstream versus the numbers we'd get off a side stream?
I'm not aware of anything that has been studied in that situation. The only, I guess, example I could give that would impair a side stream is if you have a high fresh gas flow that basically dilutes your sample before the side stream can aspirate that sample.
Sure.
So if you have, like a very high fresh gas flow, sometimes like tiny patients that have a very rapid respiratory rate, since there is that delay, it may not be as accurate in those like very rapid, like shallow breathing patients.
Okay, that makes sense. Does that affect like when you say high gas flow, does that mean like non-rebreather level gas flow can affect it?
Typically, yeah. So if the waveform on a non-rebreathing system is often less pretty or not as like good of a square waveform as a rebreathing system. So
that makes sense.
Some of the high fresh gas flow will kind of flush out typically flush out the like end of your Capnograph waveform. So you may lose kind of the back half of your square waveform.
Okay. That's actually really helpful because I do see that with the non-rebreather that I fight with those a little bit more to get a nice waveform. Yeah. And yes, maybe I don't need to fight with them as much and just say it's a non-rebreathing system.
Typically, yes. So, and I say to the 200 to 300 mil per kg per minute, oftentimes like the way you can see what kind of the lowest level of gas flow on your non-rebreathing system is I just turn the CO2 down or turn the oxygen flow down until I start to see rebreathing and then go a little bit above that. So that's kind of like the lowest oxygen flow rate you can safely get away with, basically.
Yeah. So can we talk about that a little bit? Because I understand, certainly I think we've gotten away in a lot of cases from like the 2 and 2. Mm-hmm. But, and, isoflurane, that's a whole other discussion. But I understand that our oxygen flow rates for rebreathing systems can actually be substantially lower than what we've used in the past.
Absolutely.
Is it kind of the same idea when you're trying to determine that flow rate?
With a rebreathing system, you can't really go off of that since you are using your Sotazor basically so your baseline is not going to change like with a non-rebreathing system. But in Europe, especially because of the concerns about the environmental contribution of our inhalant gases, they're terrible greenhouse gases.
Right.
It has become more popular to use kind of low flow rates. So in our practice, we often will use kind of 0.5 liter per minute, so pretty low oxygen flow rates. Kind of the downside of that, if you don't have a gas analyzer that's giving you inhalant numbers, so your end-tidal inhalant numbers, your vaporizers are precision vaporizers to a certain point. The lower the gas flow rates, the less precise they're going to be. So you may actually need a bit higher of a dial setting. So that's why it's easier to kind of titrate if you have a gas analyzer if you're trying to do those very low flow rates. So for general practice, it may be a little more difficult because it's hard to know what your patient's inhalant level is at. But I very routinely will go, at least if I don't have a gas analyzer, at least to like 1 liter per minute. Sometimes I'll go down to, again, that 0.5, but then you may have issues with your patients waking up because, again, you have a lower flow rate going through your vaporizer, so it's not picking up as much of that inhalant.
That makes sense. And so when you're doing those really low flow rates, you're using a gas analyzer that's telling you exactly how much ISO your patient's getting. So if you get down to like 0.25%, you're like, this probably isn't enough.
Absolutely, yeah.
Oh, okay.
So basically it's giving me my inspired and expired inhalant setting. So inspired and expired ISO setting. So
I didn't even know that was an option. That's cool.
The expired ISO setting basically I'm using as the pseudo measurement of what the concentration is in the brain, which is the basically site of action of your inhalant.
Okay. Very cool. Very cool. So that's I feel like a good general practice guidance that you gave there to say, yes, you can reduce it from our 2%, because I've heard that about there's concern about air pollution with the inhalant gases. But yeah, as we get low, we should probably watch our patients and find the happy medium there.
Yep. It can be a little bit, again, harder to titrate because of that kind of difference in concentration from the vaporizer.
No, that was, again, like another light bulb moment, though, where, I feel like people are saying, turn the gas down. And I'm like, okay, but why? And that makes a lot of sense.
Yeah. I think for general practice, it is, again, I was also trained in the start ISO at 2 and your oxygen flow rate at 2 to kind of flush your system. But for kind of normal, I guess, when you're in the maintenance phase, I think turning your fresh gas flow to even 1 is going to save you a lot economically. And then, again, saving the environment.
Yeah, absolutely. I know. And now we're going to like oxygen generators and all this. It's a whole new world out there. When we are looking at our waveform for our capnograph, what is kind of our ideal range that we're shooting for to tell us, okay, we have good cardiac output and our patient is stable, they're breathing appropriately? What are we looking for there?
Yeah, so in a normal awake patient, or like what you or I are breathing, our end tidal or our expired CO2 is typically between 35 and 45 is what we try and shoot for. That being said, under anesthesia, a lot of our anesthetic drugs are going to cause some degree of respiratory depression, and most of your healthy patients are going to tolerate an end tidal up to probably 55 millimeters of mercury. If I have a patient spontaneously breathing, I don't really bat an eye if they're sitting in the low 50s. CO2 actually acts as a little bit of a sympathomimetic, and so you can actually get a bit of improved cardiac output and improved or kind of in maintaining good heart rate and blood pressure with a little bit of a low increase in CO2. So we often call that permissive hypercapnia. And so again, that's for more of your healthy patients that can tolerate that. That being said, there's some disease states that probably not so much. So your intracranial, if you're worried about intracranial disease or increased intracranial pressure, CO2 can cause some cerebral vasodilation. So, and I would probably be a little bit more tightly controlled in my end tidal CO2 in like a case like that.
That makes sense. What about intraocular pressure? Do we worry about that? Does that go along with the intracranial pressure or not so much?
They often go hand in hand, so I think it's not a bad idea to kind of use the same guidelines or, again, titrate to the same 35 to 45 in those cases.
That makes sense. Although I did just learn, I feel like I'm behind the times here, about ketamine for status epilepticus, and that blew my mind because I was like, wait a second, but what about intracranial pressure and all of this? But the permissive hypercapnia is still the same for intracranial pressure. We want to watch that in those cases.
Yeah. So in those brain cases, I try and keep my CO2 probably around 35 to 40 in those situations.
Okay. That makes sense. And I feel like a lot of spontaneously breathing patients do kind of stay in that range, obviously depending on what drugs we gave them and what we're doing.
Yeah.
Let's talk a little bit about desaturation and oxygen and things like that. Are parameters like cyanosis helpful? How do we use our capnograph to help us monitor for compromise in oxygenation in our patient? Because what I've heard more recently is like, if your patient is blue, you're way behind the game here.
Yeah. So CO2 and capnography isn't going to help you as much with the desaturation side of things. It is so that's where your pulse ox and I guess visualizing the cyanosis is kind of the two big things for that. The one case that CO2, if you're trying to troubleshoot desaturation, that CO2 can help with is this. I see a lot with patients that are sedated that have some of the respiratory depression from sedation, but we don't often put full monitoring on those patients, or we don't always put flow-by on those patients. So if you have an increase in CO2, by definition, that is hypoventilation. And hypoventilation can cause hypoxemia because basically if you don't have them on supplemental oxygen. So there are basically 5 causes of hypoxemia, hypoventilation being one of them, but it's an easy thing to kind of rule out by just giving them supplemental oxygen and increasing their oxygen stores, basically, or the oxygen exchange in the lungs. So even though they'll still have a high CO2, you are providing or increasing that oxygen gradient to overcome that desaturation.
Okay, so let me make sure I'm understanding correctly, because I'm thinking of a sedated patient who is not intubated. So potentially we could get a CO2 reading with a tight-fitting mask and a capnograph.
Yeah.
And if we're seeing an elevated CO2, then providing flow by oxygen, it doesn't mean we necessarily have to like reverse or intubate or something like that, but just providing flow by oxygen and saturating that hemoglobin can be enough to help with that patient's hypoxemia. Are they hypoxic at that
Yeah,
point?
absolutely. So the other way I guess I explain this is that you constantly are producing CO2, and then most of the air you're breathing right now is nitrogen. So if you have a patient that is heavily sedated, they're going to constantly produce CO2. They're going to then consume the oxygen that's in the lungs, and so then mostly they're left with is nitrogen. So if you basically then provide them, so that's why they basically then desaturate, because they're kind of using up the oxygen that is there, because the CO2 is somewhat displacing it as well, because you have constant CO2 production and gas exchange. So if by providing supplemental oxygen, you're basically washing out that nitrogen and replacing, instead of 21% oxygen, you're now up to 100% oxygen. So you have, again, more of a store of oxygen in your lungs. This is also kind of the plug for pre-oxygenating patients.
Yes, I've heard this. It was really funny. I took the Anesthesia Institute. It's now Skill Shop, but it was instituted at the time with Dr. Mama, and she's from Colorado State. And she was like, it's so interesting here. We sedate patients and nobody's turning, or when we induce, no one's turning blue. And I was like, is that a thing? Which apparently it is in Colorado. Mm-hmm. And that makes sense. But yes, I did take that away from that course with her, of just pre-oxygenation really buying you time during that induction.
Absolutely. Yeah. The kind of big study on pre-oxygenation was actually done at UF in like our spay-neuter labs, but they basically pre-oxygenated for, I think it was about 4 minutes with a tight-fitting mask, and then made them apneic with propofol, and they had about 4 to 5 minutes before they started to desaturate. So wow. It does buy you a good amount of time even if those patients are apneic.
Wow, 4 to 5 minutes. I mean, that gives us a good window to work with. We hopefully can get them intubated and get control of that airway. Mm-hmm. Does it have to be with a tight-fitting mask? Because, of course, not every pre-medded patient will tolerate a tight-fitting mask.
Yeah. There was another study that looked at just flow-by versus a tight-fitting mask, and it really does have to be a tight-fitting mask.
Okay.
Just the flow-by, it doesn't really wash out kind of the nitrogen in the lungs as well.
We're mostly making ourselves feel better.
Exactly.
Oh, that makes me so sad.
I know.
And when we say tight-fitting, are we talking like rubber seal, or can it just be like a mask that's an appropriate size to the muzzle that's kind of concentrating that oxygen?
I think for the study they did one with a rubber seal, so I'm not sure. I don't know if it's been studied just if you have a good fitting mask. I think that probably is better than just flow by.
Right, that makes sense. Better than nothing.
Yeah.
Okay, all right.
The interesting thing I've seen that I've tried a handful of times, and again, only for very heavily sedated patients, is just taking a muzzle and putting the mask basically in the muzzle, and you can snap that on. So if you don't have as many hands, it's holding that on to the patient.
And now they make like oxygen muzzles that you can plug your oxygen directly into that are really neat and will hold everything in place. So yeah, there's all kinds of options out there that we can do, as long as as long as our patients are tolerating it. But it sounds like the ones we're really worried about hypoventilating are the ones that are going to be more heavily sedated. Absolutely. And so those are the ones where we could probably get a tight-fitting mask on.
Absolutely, yeah.
Sure. No, that makes a lot of sense. Oh, species. Let's talk about that. Yeah, let's talk about capnography in different species. Very minuscule experience with tortoise anesthesia.
Yeah.
And that's a whole different animal. No pun definitely intended. Yes. When we're talking about anesthesia, certainly, but definitely capnography.
Yeah, I guess that is another reason why capnography is my favorite, is because, in a lot of your exotic species that you can't get various monitoring on, you can typically still put a capnograph on. So for reptiles, for example, your pulse ox is very hard to find a spot for a pulse ox on a reptile besides, I guess, maybe the tongue. And so with a lot of the smaller reptiles, they might take a small endotracheal tube, but I've also adapted catheters, so large bore IV catheters. Reptiles tend to be easy to intubate through their glottis. They're not as difficult as mammals, thankfully, but you can hook up. There's a lot of different adapters that have kind of a narrower diameter, basically, or a narrow lumen to them, so you have less dead space, but then you can still connect like a side stream capnograph too. Or I see a lot in exotic practices using an EMA, which is a mainstream capnograph that has both like again, an adult and a pediatric lumen, so you have less dead space. So it is great because your reptiles, again, it's very hard to get other monitoring. We don't really have blood pressure monitoring on them in most cases. Pulse ox are hard to get. Most people are just placing a Doppler, so you hear the nice whooshing of the heart.
Yep.
But the capnograph, again, it tells you more, again, your respiration, your ventilation, a little bit maybe about their hemodynamics. So it's great for the exotics. Yeah.
Sure. And they're not breathing super often. It's been a long time since I've seen one of these under anesthesia. But I feel like I remember sitting there and just waiting for minutes sometimes, and then we would get this waveform.
Absolutely.
And apparently we were all okay with that.
Yes. Reptiles, nothing is really an emergency. You've got some time, unlike some of your small mammal or bird exotics.
Sure. What about like rabbits and things where we worry about intubation and, them passing under anesthesia? I would imagine, one, getting them intubated, and then capnography being a hugely useful tool in those types of species. It's just kind of the same concept as dog and cats, or is there anything unique about those types of animals?
Pretty similar to dogs and cats. Some people, so if you're intubating rabbits blindly, which is what a lot of people do, most practitioners you are listening for, so basically you're poised trying to listen for the sound, but you could potentially hook up a capnograph, and as you get close, it helps you confirm because you can't visualize that you're in the trachea, so the capnograph kind of is a dual way. Most are seeing basically condensation in the tube is how a lot of people are confirming, but your capnograph can be another way to confirm that you are intubated properly. I also use it because I think the tubes can get dislodged easily.
Okay,
so if I'm worried that moving those patients around, if I'm worried that they've gotten extubated, my capnograph might be a very rapid way to tell that.
That makes sense. What about like do you use V-gels or anything like that? and will capnographs work with those?
So V-gels, there's both the rabbit and the cat ones, and my experience is more with the cat V-gels. There is technically like a cuff on the V-gel, but I find that you can inflate, but I find that the seal is not as good as just a normal endotracheal.
Okay.
That being said, you can still get somewhat of a CO2 waveform. It may not be as beautiful of a waveform, but it is still possible. I personally use them for a lot of bronchoscopies because then for like the cats, they can fit the scope through the V-gel a little bit better than an endotracheal tube. So that's the thing that I've been doing more so lately.
Sure, that makes sense.
Yeah. So in those cases, I can still keep my capnograph. It might get washed out when they put it past the scope,
Sure.
but it still gives me a little bit of something.
Okay. And gosh, I feel like we've like come up with so many other conversations that could be had, like V-gels, yes or no, isoflurane. Well, that's a whole nother conversation there as far as, what rate you run your isoflurane at and multimodal anesthesia. But in the spirit of not getting too far down the rabbit holes in my brain, rabbit holes, I'm full of puns today. Sticking with capnography, a couple other questions I had. One had to do with spontaneous ventilation, because I feel like it can be, especially when you're looking at a capnograph wave and you can see how long it's been since your patient has taken a breath, it can be so tempting to intervene and give them a breath. Mm-hmm. But of course, then in some cases, we're working against ourselves because we're not going to stimulate spontaneous respiration. So what's your thought on that as far as how long we can or should wait to give a breath, and at what level will a patient start to spontaneously ventilate?
Yeah, so what I will say, and unfortunately I feel like this is the case for a lot of anesthesias, it kind of depends.
Sure, universal answer to medicine.
Yep, yeah. Exactly.
Yeah.
If it's right after induction, where I think that they're likely not breathing because of potentially the propofol you just gave, I'll wait for probably 30 seconds, like give only like 2 breaths a minute, because they will, if you have them on 100% oxygen, they're likely not going to desaturate.
Sure, that makes sense.
And they often, yes, CO2 is basically the impetus to breathe for mammals. So you need that to build up for a certain period. I guess I will wait for probably, again, that kind of 30 seconds to a minute until the propofol is kind of wearing off. The downside, I guess, at induction is that you do need to breathe for them a bit so that they can uptake the inhalant. Because your propofol is wearing off, your inhalant is kicking in. So I do, I guess, at the beginning, give them probably 4 to 6 breaths a minute just so that they uptake adequate inhalant so that they don't get light on you.
Yes, I've had that conversation with my anesthetized patients where I'm like, I need you to breathe because otherwise you won't stay asleep.
Absolutely. During the maintenance phase, a lot of patients, because of the drugs you've given, are going to have a bit of a higher end tidal CO2. So if they spontaneously ventilate at the 50s, I don't tend to worry about it because basically your anesthetic drugs are also going to reset their normal set point. So they're going to be less responsive to CO2. So that's why they may not spontaneously ventilate until they're in the 50s. So if you want them to spontaneously ventilate, you kind of may have to allow it, which again, most healthy patients are going to tolerate that. If you are trying to really rigorously keep it within the 30 to 40, it may be a little difficult.
Makes sense. But if we have a patient who has an end tidal of 35 and we're breathing for this patient, I mean, the chances that patient is going to take over and start breathing on their own are diminishing when we're keeping it that low.
Exactly. Absolutely.
Okay. No, that's helpful. I feel like you illustrated the it depends part, but then also, kind of some general parameters to look for.
That's why, I put a lot of patients on mechanical ventilation. And so if they're trying to breathe over top of me and I'm trying to capture them, oftentimes I will hyperventilate them for a bit, trying to drive those CO2 levels down so that I'm decreasing their inherent respiratory drive.
That makes sense. Kind of the last question I think I have, unless my brain comes up with more, would be barriers to capnography, which I think are diminished now compared to even just a few years ago, because certainly there's a cost consideration, training and knowing how to use them, everything like that. So what are your thoughts as far as, if you talk to somebody about the benefits of capnography and they say, well, I'm not sure if I can make it work in my practice. What are some of the common barriers that you encounter?
I think a lot of it comes down to cost. I think that we are very good at investing in a lot of other aspects of practice, and anesthesia often gets, I think, a little bit neglected. And a lot of the big multi-parameter monitors can be fairly expensive if you want kind of all in one. But I think the nice thing is there's been a lot of new companies coming out with more affordable capnograph monitors. The Emma is pretty easy to use now. Is it Vetcorder that also has some very kind of small pocket almost different monitors that has capnography included. That's only a few $100s. So I think it's a very valuable thing and worthwhile to invest that money. I think, as you mentioned, the training is another aspect of it, but I think there's a lot of very useful or helpful kind of guides online, or basically cheat sheets that give you, there's various posters I've seen at different practices that you can put up in your surgical suite that basically show you the common capnography waveforms, which are good resources to guide you and your technicians if you're just starting to use capnography.
Sure. No, I think that makes a lot of sense to say there's a ton of resources out there to learn how to use them. And like you mentioned, the different companies that are making them. I know I've talked to Lila Proenza, who does a lot of exotics, and she has the same sentiments where she says, there's these new companies that create these products that are, less expensive, and it does make it more accessible for different scenarios, depending on what we're doing. Although I do love a good multifunction monitor. It's so nice to just look at one screen, but you're right, they are pricey.
Yeah. The nice thing, I guess, if you're doing field work or, again, exotics, a lot of those portable monitors are super helpful if you're in the field. And so if you're doing field settings, you can bring those as well.
Absolutely. When I was doing mobile practice, I had a Vetcorder. And the nice thing about those, they're Bluetooth. And so, if you need to have it on a bigger screen or multiple people can see it as opposed to the little tiny screen that comes with it, there's a lot of options there. So, yeah, I mean, absolutely. I think and that's where I see the barriers. I feel like even just a few years ago, it was substantially more expensive, and it's becoming a little bit more accessible.
Yeah, absolutely.
Dr. Shippey, this has been a great conversation. I love talking about capnography, and I came up with 4 other ideas of conversations I would love to have that I had to rein myself in to keep from going down the rabbit holes. So thank you for joining me. Are there any final thoughts you want to share?
I think we covered a lot of things. I'm always happy to talk about capnography, happy to talk about anything anesthesia related. I think a lot of people get very stressed out or nervous about anesthesia because it's a lot of pharmacology, a lot of physiology, but if I can do at least a small part to make it more understandable, then I'm very happy to do that.
Absolutely. Absolutely. Well, thank you again. Dr. Shippey, thank you so much for coming in and joining me at the studio. I had such a great time recording this episode with you. A huge thank you to everybody out there who tuned in. I hope you learned a lot. Like I said, some of these concepts were things, I talked about many times before, and Dr. Shippey just made them make sense in a different way than they had clicked for me before. So I hope you guys all had some light bulb moments as well. If you did enjoy this episode, please, please, please leave us a 5-star review wherever you get your podcast to help other veterinary professionals like you find this and other great content we try to put out there. For more episodes like this, you can click on the Education tab on the Vetfolio website or find us wherever you get your podcasts. As always, I want to hear your thoughts on this episode, as well as what sorts of topics you'd like to hear from us in the future. So email me at dvm@vetfolio.com. We can also connect on Facebook at Dr. Cassie DVM, or we can connect on Instagram at dr.cassie.dvm. And remember, if one animal is better off because of you today, it's a great day.